Hey everybody, and welcome back to another video here at Whiteboard Doctor. We hope everyone's having a good day. Today we are going to dive into a really interesting topic, a topic that has really grown in the last, 5 to 10 years, and that is left ventricular assist devices, also known as LVADs. In this video, we're going to dive into the basics of all things LVADs. We're going to talk about what they are, how they work, who they are best suited for. We're going to talk about the anatomy, the physiology, indications, contraindications, pump parameters, evaluation, complication. We'll go into some basics of alarms and all that kind of stuff. So whether you are a patient or a medical professional or trainee, you should hopefully find some good information in this video. No further ado, stick around. Don't go anywhere. 30-second break for the introduction. We'll be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So LVADs are left ventricular assist devices. So these are devices that are placed into a patient's heart to help pump blood around that patient's body. Right? Left ventricular assist devices. We'll get into the anatomy with some graphics down below, but the left ventricle is the part of the heart that pumps blood to the rest of the body, right? The brain, the arms, the legs, the intestines, the kidneys, the liver, all that good stuff. The left ventricle pumps blood there. So this is a left ventricle assist device, aka a device, a machine meant to assist the left ventricle in pumping blood to the rest of the body. This was birthed for those who have heart failure. Many are probably familiar with what heart failure is. It affects a lot of people, 6.5 million people worldwide, or I should say in the USA. Worldwide, it's more than 4 times that, or right around that, 25 million people worldwide. And of those individuals with heart failure, up to 5% will progress to end-stage heart failure. And that's despite medical management, right? There's a lot of medications that patients with heart failure take. Some of you watching this video may have heart failure or treat patients with heart failure and see these patients or take these medications. Things like beta blockers, things like ACE inhibitors or angiotensin receptor blockers. We're kind of getting into these other medications like empagliflozin, et cetera, et cetera. And those medications are effective, right? If you have heart failure, those medications do work. They do improve outcomes. But despite that, there's still a percent of patients, up to 5%, that will progress to end-stage heart failure despite taking all those medications. And really at that point, you have very limited options, right? The cure would be heart transplant. But there's patients who don't qualify for heart transplant. There's some patients that don't want a heart transplant. And even of those who do want a heart transplant and do qualify, there's not enough hearts to go around, right? Because unfortunately, to get a heart, someone has to donate a heart, right? So there's lots of patients with end-stage heart failure who either are waiting for a transplant, don't qualify for a transplant, or don't want a transplant, who may benefit from a left ventricular assist device. In fact, when they look at the numbers, what they have found is that there's been a huge decrease in mortality, all right, and that's death. All right, when they first started studying LVADs, the 2-year mortality for those on medical management was about survival was about 5%, something like 5 to 10% at 2 years for end-stage heart failure. But when they came out with LVADs, the most recent, the HeartMate 3, which is the most recent LVAD out there, at 2 years, I should say the survival. Let's do that because I think this is going to be confusing. So the survival at 2 years for those without an LVAD, 5 to 10%. This is probably going up, right? That study was a number of years ago, so their survival is probably a little higher, even in the non-LVAD group. But with those with a HeartMate 3 at 2 years, I think the most recent study was somewhere like around 75 or even closer to 80% survival at 2 years for those that got the HeartMate 3 LVAD. So you can see huge improvement in survival, right? Quality of life and all those kinds of things benefit from having this left ventricular assist device. So as you can see, this device does seem to help people It's really interesting though. We're going to come back up to this picture to talk about the components of the device itself. I want to start with a more simplistic drawing on the anatomy and physiology. And to understand what an LVAD is doing, we have to understand how the heart works. Okay, so this is a depiction of a heart. For those of you familiar with this, bear with us. For those unfamiliar, the components we have here, this is the right atrium. Okay, the right atrium gets venous blood. This is deoxygenated blood from the body, so it's already pumped around the body and it's coming back in the veins through the inferior vena cava, the IVC at the bottom here, and then through the superior vena cava, the SVC at the top, and it pumps into the right atrium. Okay, that blood goes through the right atrium. This is the tricuspid valve into the right ventricle. The deoxygenated blood in the right ventricle then goes through the pulmonic valve right here, and this gets pumped into the lungs. Okay, the lungs obviously oxygenate the blood, and then they pump it back to the left side of the heart into the left atrium. That oxygenated blood goes through the mitral valve into the left ventricle, and then it goes out the aortic valve, right, up the aortic arch, and this is where the oxygenated blood starts going to the body, right? There's these arteries that come off the aortic arch that go to, the head, the brain, the arms, with oxygenated blood, and then the descending aorta kind of comes down this arch, goes behind the heart, right? So I'll put a dotted line because it's kind of behind the heart. And this is the aorta, and this takes all that oxygenated blood that goes to the rest of the body, right? Kidney, liver, legs, etc., etc. I don't need to write it all out. So if we were to kind of zoom out and draw it on this nice stick figure, very happy, they're smiley because we're talking about LVADs today. They have a very long neck, apologies, and I'm going to draw their heart a little bit low, right? So the heart's going to be kind of sitting below their arms. And stick with me, I'm not the best of the drawers, but what we have here, right atrium over here, right ventricle here, left atrium, left ventricle, and the oxygenated blood gets pumped out of the left ventricle, right, and it goes down. Oh, let us mute this, apologies. No, that's not what we wanted to mute, good. Goes down the aorta, and the aorta kind of branches tons of arteries, right, off of it, right, to go to the bowel, to go to the kidney, right, and it comes down and branches and goes down to the legs, right? There's the iliac arteries, femoral arteries, the celiac artery, superior mesenteric artery, inferior mesenteric artery, renal arteries, etc., etc. So all this is oxygenated blood, blood with oxygen. So you see that left ventricle is critically important. If that left ventricle can't squeeze adequately, then we're not going to be able to pump the oxygenated blood to the body. You can't live, right? If you can't get oxygen to your tissues, you can't live. Your tissues will die. They need oxygen to live. So patients with heart failure have a decreased squeeze. Their left ventricle, there are some subtypes of heart failure, and we won't discuss it in this lecture. There's diastolic heart failure and systolic heart failure, but we'll maybe do another video on heart failure if y'all are interested. But the heart cannot squeeze adequately, right? Quite literally, the heart contracts. This left ventricle squeezes inward and contracts in, and then it pumps that blood out the atrium. And there's a valve here that's closed, right? Or sorry, out the aorta. So this valve's closed, so blood can't go back to the atrium. It comes out of the left ventricle and goes into the aortic outflow tract, aortic arch, and out the aorta to the rest of the body. So if this is not squeezing as well, it's called heart failure, right? An ejection fraction is kind of what we measure it in. And a normal ejection fraction is, usually above like 55%. So heart failure is when you have a low ejection fraction, not able to eject blood out of your left ventricle as well. And it's literally a percentage, right? So normal is greater than 55%. So people out there without heart failure, the percent of blood they're ejecting out of their left ventricle, if we say, the whole left ventricle is 100%, you eject normally about at least 55% of blood out of your left ventricle. When you have heart failure, that number's way down. And you can imagine, right, if your ejection fraction is only 10%, you have severe systolic heart failure because you're only ejecting 10% of the blood out of this left ventricle. The rest is just sitting in there because you have a weakened squeeze, a weakened heart. And that's where the left ventricular assist device comes in, the LVAD, right? Because that left ventricular assist device helps pump blood around the body. So I'm going to zoom into this graphic over on the side here, and we put a citation below it. It's not our work, so we'll link this study in the video description if you want to kind of go to it, but credit where credit's due, this is their image. But it shows a pretty decent outline of what these devices look like. So hopefully this looks like the heart, right? This is the right atrium, right ventricle. This is that pulmonary outflow tract that goes to the lungs, right? Then that blood comes back into the left atrium, left ventricle, and then here's that aortic outflow tract, aortic arch. So what the left ventricular assist device is doing is they surgically implant this tubing into the left ventricle. Literally, it goes through the wall of the heart and sits into the left ventricle. This is the inflow cannula, but don't get confused on inflow because it's actually inflowing into this pump, right? So it's sucking blood out of the left ventricle, sucking blood out of the left ventricle into this pump, and we'll talk a little bit more about the pump. That pump then pumps the blood to the outflow cannula out of the pump, and this is surgically implanted into the aorta, okay? So as we said, the aorta is what pumps blood to the rest of the body. If we go down to our terrible drawing here, this is the aorta, and the aorta pumps blood to the rest of the body. So the LVAD has part of its tubing here. It sucks blood out of the left ventricle. It goes to, a nice pump, and that pump then shoots that blood through another outflow cannula directly into the aorta, and then it pumps that blood into the aorta so that the oxygenated blood can go and get to the rest of the body. So if we look back up, right, you have your inflow cannula, and when they talk about inflow, it's as compared to the pump itself, so it's flowing into the pump itself, sucking blood out of the left ventricle through the inflow cannula into this pump. The newest LVADs, the HeartMate 3, and there's multiple kind of LVADs out there, but HeartMate 3 tends to be the newest one. This type of pump is an axial pump. It actually uses magnets. There's no kind of bearings or anything, which we'll get into a little bit. And then that pump pumps that blood to the outflow cannula that's surgically implanted into the aorta, and that pumps the blood around. So people are walking out in the world with this. This is a person, right? And they have their LVAD, right? We talked about here's their heart. The LVAD sucks blood out of the left ventricle, goes through this pump, goes into the outflow tract, into the aorta, and then that blood gets through the aorta and kind of goes down to the rest of the body, as it would. But what you can see here is that this individual, you wear the LVAD, right? You wear it on your person because what you need is you have this cable. You see this cable right here that is in the body, comes out of the abdomen, and then is connected to this pack. This is called the drive line, right? And the drive line is how this pack here, all right, this is the external control unit, controls the LVAD itself. This is how you can change settings and things. You could look at settings. And then you have your two battery packs, right? Because this needs to run on battery. So when you're at home, you could be plugged in, but when you're walking around in the world, you need battery packs to then run this. Without battery, the pump cannot run itself, right? The pump will die. It needs battery just like anything else. So you can see that people with LVADs kind of walk around with all these things, but as compared to, them just taking medical therapy and not surviving, this is, in many people's mind, a big upgrade, but certainly it's patient dependent. Obviously everyone has different preferences for how they're willing to live, but that's what the general structure looks like for people who have an LVAD, who are kind of out in the world. I'm going to zoom back out. Let's see, let's zoom in just a little bit. Okay, so we talked about the anatomy, physiology. We talked about what that looks like. What are the indications? Who benefits from an LVAD, right? I told you there's an increased survival at 2 years, okay? There's decreased symptoms for many people with end-stage heart failure. But there are specific indications for who qualifies for an LVAD. Obviously, this is a surgery. It's a significant surgery. These patients need really close monitoring at outpatient appointments. They need to be on special blood thinning medications and all that. So these are all subjective, but some rough guidance is that ejection fraction, right? How much that left ventricle, LV, left ventricle EF ejection fraction can pump blood out. It's got to be very low, less than 25%. These are all kind of dense details, and I'm going to skim over these briefly, but for those interested, certainly can do a deeper dive later on. But NYH, New York, is it Heart Association? I think so. This is classes of heart failure based on symptoms, and this is essentially advanced symptoms of heart failure. These symptoms and ejection fraction need to be refractory despite optimal medical therapy. So you can't just not have started any medications and come with this heart failure and get an LVAD. And then patients who are really sick, they're on inotropes, which are medications that help the heart squeeze harder, or mechanical circulatory support like an intra-aortic balloon pump. We've done a video on intra-aortic balloon pumps, so definitely check that out if you're interested. So all these patients would qualify. But in addition to that, there has to be something more, right? Because LVADs are a really significant kind of investment. So who benefits most? Well, those with these symptoms, and then also as a decisional tree based on bridging to a certain endpoint, right? So those who qualify for a heart transplant, while they're waiting to get that heart transplant, they can get an LVAD as a bridge to transplant, right? Help them survive until they can get a transplant. In addition, those being worked up for a transplant, they can get an LVAD as a bridge to a decision if they're going to qualify for a transplant. Sometimes people's hearts get really sick, right? But if you expect that heart to recover, you can get an LVAD as a bridge to recovery. And then once you recover, you obviously don't need the LVAD anymore. And then now we actually do it as destination therapy too, which means for patients who don't qualify for transplant, they're not going to recover, and it's already been decided, right? So it's not a bridge to transplant, it's not a bridge to decision, it's not a bridge to recovery, but they have end-stage heart failure. We've now seen that people can live, some people can live better, quote unquote, better lives with LVADs, less symptoms, longer lifespan. So it can actually be a destination therapy, right? They're not going to end up with a transplant. The heart's not going to get better, but they get an LVAD, so they can live a more kind of fruitful life until they succumb to their disease. So it's destination therapy. So you'll see these sometimes, right? Like bridge to transplant, destination therapy, all that. That'll often be in like the advanced heart failure note and those types of things. So these are the indications: those with end-stage heart failure, despite medical therapy, as then a bridge to transplant, bridge to decision about a transplant, bridge to heart recovery, or as destination therapy. All right, are there contraindications? Are there patients who can't get an LVAD? Well, some of these contraindications are what we call kind of hard or absolute, and some are kind of soft contraindications. One is right heart failure. So as we mentioned, there's two sides of the heart. You can even put a line right down the middle. Right, so you have the left side, right, left atrium, we talked about this, left ventricle, and then you have the right side, right atrium, right ventricle. And as we said, the right side pumps blood to the lungs, so it goes out to the lungs, and then it comes back in to the left side of the heart, right, and be kind of a dotted line to the left atrium, goes to the left ventricle. And then the LVAD sits in the left ventricle, pumps blood out to its motor, right, which then pumps blood to the outflow tract into the aorta, and then that blood that the LVAD pumps into the aorta gets shot out to the rest of the body. But to get blood to the left side of the heart, the right side of the heart has to work, right? Because that right side of the heart has to pump the blood to the lungs that then returns to the left side of the heart to get pumped to the rest of the body. So if the right side of your heart is not working, LVADs often don't help you because you need the right side of the heart to work to pump blood to the left side of the heart, if that makes sense. All right? So right heart failure can be a relative contraindication. Neurologic compromise. What this means is those with devastating neurologic injuries. Getting an LVAD, again, requires a huge surgery. You need to be on blood thinners, all these medications, frequent appointments. You have to make sure your battery life stays good. There's a lot that is required to maintain an LVAD. So if you have a profound neurologic injury, often that patient is not a great candidate to get an LVAD. In addition, coexisting severe terminal illness. So if you have another disease that you're going to die from in the near future, often they won't give you an LVAD because it's not really going to prolong your life because you're already going to succumb to that other disease. Another big contraindication is bleeding. This is a relative contraindication, but to have an LVAD, to have a left ventricular assist device, you have to be on a blood thinner, anticoagulation. Often this is Coumadin. In addition to that, you have to be on aspirin, right, ASA. So if you already have some severe bleeding issue, you can't really get an LVAD at that time. But again, that's relative. There's not too many bleeding conditions that are at least common. That would be an absolute contraindication. Usually you can try to take care of the bleeding first, give some time, and then possibly be a candidate for an LVAD. Anatomic limitations, though, is a big one. As we mentioned, I wonder if I can erase some of this because I clogged it up, although the picture's fine. So you have to put this big outflow cannula in the left ventricle. So you have to have the anatomic space to do that. Let's say you have hypertrophic cardiomyopathy where the walls of the heart are very thick. So if I were to draw another heart, right atrium, left atrium, here's the ventricles, this is right ventricle, this is left ventricle. So as you can see here, you kind of have this thin myocardial wall, plenty of space in the actual cavity for this cannula to sit. But if you had a really thickened wall, let's just say your cavity was only this big and all this was really hypertrophic heart wall, there's not really enough space for a cannula to sit in that little cavity, right? So that would be an anatomic limitation. In addition to that, technical limitations. So if you have profound obesity where the LVAD just can't physically pump enough blood around your body because you have so much adipose tissue that you can't get enough pump flow from the LVAD to get to the rest of the body, that would be another limitation. All right, so these are contraindications, but again, a lot of these are kind of what we call relative contraindications. something that the advanced heart failure team and the multidisciplinary LVAD team at the institution that you would kind of all talk about and figure out what makes sense for a patient and what doesn't. All right. The only other thing about anatomy, now that I'm thinking about it, that I didn't say is remember the heart keeps beating. So not only are you getting flow from the LVAD, so LVAD sucking blood out of the left ventricle, going through the pump into the aorta, shooting that blood into the aorta to go around the body, but the heart is still working. So even if your ejection fraction is only 15%, that means your heart is still able to squeeze 15% of its blood out of the left ventricle into the aorta. So, patients get both their native ejection fraction as well as the LVAD flow to help perfuse the body, just if I didn't mention that above. Okay, so pump parameters. This is, at the end of the day, a pump. The LVAD is a pump. And I put HM3 here because these are somewhat specific to the LVAD you have. Again, HeartMate 3 is the biggest one. I also was going to talk about alarms, but I'm going to do a separate video on LVAD alarms, kind of a deeper dive on it. So keep an eye peeled for that. We'll link it in this video's description when it is out as well. So the pump parameters, there's 4 pump parameters, all right? Speed, power, flow, and pulsatility index. And these are literal things on the LVAD itself, right? I'm going to scroll up. We said LVAD patients have this external control unit, right? These 4 parameters are on this external control unit. You can get them from that, okay? And they're relevant to how the LVAD is working and the physiology going on in the patient's body. So the speed is just that, the speed of the blood flowing. And that's in revolutions per minute RPM. And it's about 3,000 and 9,000 RPM would be kind of within the parameters of quote-unquote normal, although I think 4,000 is pretty close to normal. This is revolutions per minute of speed. All right, the power is the direct power measurement of the motor itself. So if you think about an LVAD, what you think about is that there's an actual motor, right? And the motor is pumping that blood around. So the power is a measurement of how hard that motor is working to pump the blood around. And again, that can tell you some things about the patient's physiology. If that motor is working harder or less hard, that might indicate certain things about the patient. Third is the flow. This is actually a derived and estimated value. This is not a direct measurement, right? Speed and power, these are direct measurements. Whereas the flow is derived. And the derivation is based on the directly measured speed, the directly measured power, as well as the patient's hematocrit. The hematocrit is how many red blood cell load they have going around. And this is 3 to 6 liters per minute. So the flow is the actual kind of quote-unquote cardiac output, right? The liters per minute of blood that pump is flowing around the body. It's about 3 to 6 liters per minute. The pulsatility index is a little more complex, right? So as we mentioned, the heart is still beating. As we mentioned, I'm going to do this terrible drawing over and over again for some reason, right? You have your LVAD coming out of the left ventricle, going into its outflow tract, into the motor itself, which is then going, sorry, I think I said outflow tract, but this is the inflow tract here, going into the outflow tract, which is then going into the aorta. And we'll draw the aorta here, which kind of comes out of the left ventricle into the aortic arch, into the descending aorta, the rest of the body, right? And then this outflow tract's kind of got its big cannula going into the aorta. But that heart is still beating. There's still native beats going on. So the pulsatility index is the pump, the LVAD controller unit itself averages the pulsatility of the heart, the squeezing of the heart over 15 seconds, and then translates it into a reading from 1 to 10. So as one can imagine, that pulsatility index, when the heart squeezes, it'll change how the pump is flowing, right? Because how this blood goes into the pump, this inflow cannula, would change whether the myocardium was kind of squeezed and contracted down or relaxed. So that's what the pulsatility index is measuring, right? It's measuring over 15 seconds how the pump flow changes when the heart is squeezing. And then it gives it a number again, 1 through 10, which can again be a hint for some of the physiology of what's going on with the patient. And again, look for an upcoming video on all things alarms, because I think LVAD alarms are really important, but they're kind of next level. I didn't want to include them in the LVAD basics. I think they require a little bit more discussion on their own. So those are 4 things that the controller unit of the LVAD will show you: the speed, the power, the flow, the pulsatility index. The flow is the only thing that is kind of estimated and derived. The rest of them are direct measurements, and all of them can tell you kind of about the quote-unquote normal on the LVAD. Something we sometimes talk about is like, we'll call it like the rule of fours, right? That all these should be about 4 something, right? Like about 4,000, about 4 liters per minute. All right, so kind of rule of fours can at least give you a ballpark estimate of what the quote-unquote normal is in setting of pump parameters. All right, so how do we evaluate an LVAD? This is really complex, and this is certainly not a comprehensive list, but when an LVAD comes into the clinic, or you have an LVAD, or you see one in the emergency department, you just are curious how to evaluate an LVAD, there's a handful of things you should do. The first is always to reach out to the LVAD team. They want to be involved. They follow patients with LVADs really, really closely. There's usually a coordinator on call 24 hours a day, depending on the institution you're at. Call the LVAD team, let them know that an LVAD patient of theirs is at your institution, and they certainly will probably know that patient and want to be involved. You can auscultate the heart and listen for a hum, right? You should hear a hum. This is literally the machine, the LVAD pump working, so you should always hear a hum. No hum, bad news bears. Always check the patient's battery life. Again, if the patient is not physically plugged in to charge, they have a battery, and those batteries die. And if the battery's dead, the LVAD pump is not working. So always check the patient's battery life. All right. Look at the LVAD to see if there's been any recent LVAD alarms. Remember, future video, but this gives you a lot of insight. If there's been alarms, you need to think about and address those alarms. If there hasn't been, that kind of crosses it off the list, right? The LVAD seems, there's a hum, good battery life, no alarms. That implies the LVAD's probably working okay. Certainly exceptions to that rule, but for the most part. Also look at the drive line for signs of infection. I'm going to scroll back up to that picture to remind you all what the drive line is. Right, the drive line is literally this line that goes from inside the patient's body on the pump of the LVAD, goes through their abdomen, comes out the skin of their abdomen, and plugs into the controller unit. So that's the outside world, right, communicating with the inside world, because that drive line comes out of their body, goes to the controller unit, and obviously from the controller unit, the drive line from outside the body goes back in the body, in the abdomen, to the actual LVAD itself. So you always want to look at that site, make sure there's no redness, make sure there's no swelling, make sure there's no drainage, no pain, because drive lines do get infected, which we'll talk about in a second. Always send a coagulation panel. Remember, these patients are on anticoagulation, AC anticoagulation. Most times it's Coumadin. So you want to check their INR, make sure it's not too high, not too low, get that sweet spot. Electrocardiogram and telemetry monitoring. These patients are high risk for ventricular tachydysrhythmias. So always get an EKG and have them on telemetry monitoring. Auscultate the map. This is essentially how do we check the blood pressure of these patients, right? Because blood pressure, the cuff itself, isn't always dependable. So what you can do is you can inflate a cuff and put a Doppler on the brachial artery, and then when that pulse comes back, that is going to be the map of the patient. So what this looks like is you literally put a Doppler on the brachial artery with a blood pressure cuff proximal to that, inflate the blood pressure cuff, right? And then slowly let the air out of the blood pressure cuff until that pulse returns. Good. And, a normal map in these patients, probably somewhere around 60 to 80 millimeters of mercury. Now, the blood pressure cuff sometimes will work. It depends a lot on what that patient's actual left ventricle is doing. But the LVAD itself is a machine, right? It's not pulsatile. It gets a little more complex, right? Because the HeartMate 3 does have kind of this pulsatility purge thing it does. But if you're trying to feel for a patient's pulse, you won't always feel one, even when they're doing just fine, because that LVAD itself is just sucking blood out and circulating it through. And that's just a constant flow, whereas the heart is squeezing, relaxing, which is how you get that pulse, right? Squeeze, relax, squeeze, relax. This is pulse, nothing, pulse. So if the heart itself does not have a lot of function left because they have severe systolic heart failure, so that left ventricle isn't squeezing robustly, you might not feel a pulse on these patients, even though they're doing just fine and the LVAD's working just fine. Right? It doesn't get really tricky when they don't have a pulse and they don't look just fine, but topic for another video. But try to feel a pulse if you can't feel one, though, and the patient has a good hum, good battery life, no LVAD alarms, they're awake, they're talking to you. Use this method where you inflate the blood pressure cuff while using a Doppler on the brachial artery to see what their map is, because they will have a map still. They just might not have a pulse. Okay. And then volume assess and perfusion assess these patients. So make sure they're not swollen, they don't have a bunch of fluid overload. And then feel their extremities, right? Make sure they're warm and well perfused, that they're not cold, to imply they're in kind of blossoming cardiogenic shock. So this is kind of the quick and easy evaluation for these patients. Certainly a lot more to be done here. These patients can sometimes hemolyze their red blood cells, so a CBC to look for their hemoglobin is important. If they do have a low hemoglobin, thinking about GI bleeding, but also hemolysis is important. These patients can get very, very sick, but here's kind of the quick and easy for them. All right, last but not least, complications. So LVADs are a machine implanted into the heart. So there are going to be complications. As we've gone through different iterations of LVADs, and now we're to this kind of HeartMate 3, these complications have been decreased, but they are present. One of the big complications is bleeding. Okay, specifically GI bleeding. Some estimates are kind of up to 10 to 25% of patients with LVADs will have a GI bleed at some point. And this is for several reasons. The obvious one is that these patients are often on anticoagulation, right? Things like Coumadin, or warfarin is another name for Coumadin. In addition to that, though, given that LVAD kind of sucks blood and shoots it around their body, it also can mess with their von Willebrand factors, which makes them more prone to bleeding. They can also have lower platelet counts. And without pulsatile flow, which this is going to sound bizarre, but it's true, they have an increased risk for AV malformations in their gut, arteriovenous malformations, which are called AVMs for short, and these can bleed. So all these together really increases the risk for bleeding, especially GI bleeds. In addition to that, sepsis or infection, about 20% of these patients can get an infection. Oftentimes it's from that drive line, right? We said evaluate that drive line. The drive line goes from the external world into the patient's body, so high risk for infection. Many of these patients need blood cultures, close monitoring of their drive line, and kind of always have a clinical suspicion for sepsis or infection if they're coming into the hospital for really any complaint. RV failure is another big one. And why is that? Well, it's because of what we talked about. Let's go see if we got a good picture. Right side of the heart, left side of the heart. Right ventricle, this would be RV failure. That LVAD is sucking blood out of their left ventricle and shooting it around their body. But that blood comes back to the right side of the heart. So if the LVAD is doing its job and it's flowing great amount of blood back, over time it can overload the right side of the heart. And we see that up to 10 to 50%, so kind of a wide margin of patients can get RV failure over time because that LVAD is circulating so much blood around the body, and all that blood goes back into the right side of the heart, and it can cause that right ventricular dysfunction. Aortic regurgitation, what is that? We're going to scroll back up again. Hopefully we have a picture that I just haven't absolutely destroyed. We're going to do some erasing on here so we could see a little bit better. So the aortic valve is the valve that's right here, okay? Let me get a little darker. This is the aortic valve, and the aortic valve is where blood from the left ventricle gets pumped through the aortic valve into the aorta. And as we said, an LVAD sits in the aorta, so it sucks blood out of the left ventricle and shoots it into the aorta. Over time, that's a lot of kind of pressure on the aortic valve, and you can get regurgitation, which is where blood goes the wrong way. It goes from the aorta through the aortic valve back into the left ventricle. And there's a number of reasons that can starts to happen. One of those reasons is since you're sucking so much blood out of the left ventricle, less blood is being squeezed from the left ventricle through the aortic valve, so that aortic valve can start to kind of degenerate over time. And as it degenerates, it gets aortic regurgitation, 10 to 35% of patients. The reason this is so significant is because it makes the LVAD much less effective, right? Because if I couldn't help myself, I have to draw it again. Okay, so this is left ventricle here, right? And again, you're pulling blood out of the left ventricle to the machine and then going into the aorta, and the aorta circulates blood around the rest of the body, right? So it's implanted here in the aorta. But if you have aortic regurgitation and you're shooting all this blood into the aorta, that's a lot of pressure in the aorta. And if the aortic valve regurgitates the wrong way into the left ventricle, a lot of this blood will end up going back into the left ventricle. Much less of that blood will go forward, and that'll make all of this worse. So it can really affect patients. You should always consider aortic regurgitation because many patients develop it over time. And then another one is stroke. Anytime you're pulling blood out of the body into a machine, there's a chance of blood clots forming, right? You can get blood clots in the machine itself. You can get it in the cannulas, and even having kind of these foreign bodies in the left ventricle or in the aorta. Now, this has gotten a lot better over time. This number used to be much higher, but still around 10%, people say, of patients with LVADs can develop stroke. So these are some of the big complications: bleeding, sepsis or infection, right ventricular failure, aortic regurgitation, and stroke. Although these patients are higher risk for lots of conditions, just because they're very chronically ill and they have this LVAD, this machine that's literally pumping blood around their body for them. So hopefully that was interesting, educational. It was a good kind of intro basics of LVAD. If you're interested in LVAD, we're going to be coming out with a handful of more LVAD related videos. In addition to that, our Patreon page, we're really working to buff up our Patreon page. We're going to have kind of the notes for this video on the Patreon page. We're going to have practice questions, and it's a direct line to us if you ever want to kind of talk to us or request topics or what have you. So definitely check out that Patreon page. We appreciate y'all. Stay well, keep learning. We'll see you next time.